Hello. Many a times patient presents in the ICU when he is jaundiced, and sometimes it is acute decompensation of the chronic liver disease, or sometimes it is an acute liver failure. And there have been various definitions of acute liver failure. So to discuss the various issues related to the acute liver failure, I have with me Dr. Manav Vadhaman, who is a senior gastroenterologist and hepatologist working in a liver transplant unit in the Department of Gastroenterology at Fortis Escorts Hospital, New Delhi. So Dr. Manav, what is currently the most accepted definition of acute liver failure?
See, I think there are around 40 definitions of acute liver failure. One which is most accepted and which we also follow is which talks about 26 weeks. So onset of encephalopathy within 26 weeks of onset of jaundice. And this definition actually is very important for two reasons. One, it's an all-inclusive definition, and it has been sub-classified into three parts. So you have hyperacute failure within 7 days. That's very important for our population because it happens basically in eastern part of the world. Then you have acute liver failure, which is 8 days to 1 month, 28 days, 4 weeks, and then 4 weeks to 26 weeks is subacute hepatic failure. Now, it's important to classify in this way because the prognosis is different. Hyperacutes are the worst to present, but they have the best prognosis. So the survival in hyperacute actually is much better than acutes and subacutes.
But even to say acute liver failure, it is essential that person should have coagulation abnormalities as well as absence of cirrhosis, except those exceptions.
Absolutely. So three criteria to diagnose acute liver failure are jaundice, coagulopathy, and altered sensorium in absence of pre-existing chronic liver disease. So that is mandatory. So if you find any evidence of cirrhosis on investigation, let's say the patient comes to you with jaundice, you do ultrasound and you see it's a small shrunken liver. Despite fulfilling all three criteria, it is still not acute liver failure, it is acute on chronic liver failure. So that's where the importance is. And as we talk, we'll realize that the prognosis also is different between ALF and ACLF.
So it is in the absence of a chronic liver disease or a cirrhosis when you say acute liver failure.
That's right.
So let's say there is a patient of acute liver failure. How do you proceed? The patient has landed. Of course, the intensive care part is being taken care by intensivist. As a gastroenterologist, how do you proceed, and if you are in command, how do you go about it?
So I guess once a patient has landed in the ICU, the ABC has been taken care of. So I'll start from there on. So airway, breathing, circulation has been taken care. The investigation for acute liver failure basically can be actually divided into parts. One is workup of etiology. Why is it important? Because you have specific treatment for specific etiologies, and the outcomes differ if you are able to find out and treat the etiology. Secondly, the workup for the severity of acute liver failure, and thirdly, the prognostication, whether this patient is going to require a transplant or not require a transplant. So that's how you divide your investigation into three parts. So the first part is etiological part. You want all the viral markers. You want hepatitis A, E, hepatitis B, hepatitis C. You also want the rarer causes of acute liver failure. So a Wilson may present with acute liver failure. So you want a ceruloplasmin level. You want to look at the eyes to look at whether the patient has a KF ring or something. You want to go back into the history and see whether it is an autoimmune liver failure, because autoimmune related acute liver failure again will respond to steroids. You need to identify that. So you need autoimmune markers in addition to other things. So that's the etiological workup. I guess.
And of course, the history will tell us whether there is any drug intake or any.
That's the most important part, I would say. I would say that if you have to approach acute liver failure, you cannot ignore the history. The most important part is the history. The history will give you drug intake. It will give you previous diseases. It will give you any joint pains, rashes, other things. It will give you an idea whether you are actually dealing with a febrile illness which has led to altered sensorium, which may be a systemic disease. It may not be acute liver failure. So we start with a proper good history from a Obviously, you can't have the history from the patient because the patient is in altered sensorium. So you need a reliable person from which you can take the history. You do the initial workup. You say whether you know the etiology of ALF or you don't know the etiology of ALF. Then you go on to severity of acute liver failure. So the second set of investigation is severity, and that is intricately linked to the prognostication. Whether this patient is going to go for transplant or not going to go for transplant. That's actually the question.
Now, suppose there is a patient who is a dengue positive or leptospira positive, and he has jaundice, he has encephalopathy, he has coagulation abnormalities. Will you call this as an acute liver failure?
So, this is a very important question. I'll spend some time on this. To define acute liver failure, see, acute liver failure can be manifestation of a systemic disease. But when we say ALF is garden variety primary hepatocellular disease. So if you have a systemic illness, if you have dengue, if you have leptospira, if you have malaria which is affecting liver and causing jaundice and altered sensorium, it is not a garden variety acute liver failure because treatment as well as the prognostication is different and you don't have an option of transplant here. The most important thing I would say at bedside when the patient comes to you and you see the basic set of investigations. If you see a normal INR or a mildly deranged INR, be suspicious of a diagnosis of acute liver failure. ALFs will have high INRs. So you'll invariably have INRs which are 3, 4, 5, 2.5. If you see a 1.5 INR with a febrile illness before, with altered sensorium and jaundice, look at systemic causes. Second important indicator is platelet count. If you have a low platelet count to start with an acute liver failure, you're probably not looking at acute liver failure. You're looking at a systemic disease causing acute.
Or some other disease. Or maybe a
chronic liver disease for that matter. That's right. So these are two things which you should very carefully look at, a prothrombin time and a platelet count.
You think they really guide you to differentiate a topical?
Absolutely. I'm convinced.
Okay, now a patient has landed in my ICU with acute liver failure. How to prevent deterioration in acute liver? Can you do it?
Actually, yes. So, to prevent deterioration, we have to first understand what causes deterioration in acute liver failure. So, you have to act before these things set in. So, if you look at causes of mortality in acute liver failure, the primary cause of mortality in acute liver failure is cerebral edema. So, you have to do all measures to prevent cerebral edema. The patient already has some edema. See, if somebody has grade 3 encephalopathy, there will be element of cerebral edema. That is the reason the patient is in encephalopathy. But you have to end the cascade, you have to prevent further deterioration. So everything you can do to prevent cerebral edema, you have to do. If you are able to prevent or decrease cerebral edema, the prognosis improves, the deterioration improves. The second most common cause of death in acute liver failure is infections. So again, you need to prevent infections. I think one of our important questions is whether antibiotics are required or not. I will actually take these two things together. So if you see the level of evidence for use of antibiotics in acute liver failure, you will not get any. You will not have class 1 evidence of antibiotics with or without antibiotics survival in acute liver failure because nobody will be able to give you a randomized control trial. But across all centers, across the world, and even in our center, the dictum is if you have grade 1 encephalopathy, early ALF, mild derangement, probably you don't need antibiotics. But the moment you start having one organ deterioration, which includes grade 3-4 encephalopathy, which includes saturation problems, which includes renal dysfunction, the patient has to be on prophylactic antibiotics even without evidence of infection. If you are able to prevent infection in high-risk acute liver failure.
Single organ failure in addition to liver failure.
Yeah, so but mind you, grade 3-4 encephalopathy is also considered a severe acute liver failure. So see, we understand that ALF is defined by altered sensorium, but we have to differentiate our patients into grade 1-2 and grade 3-4. So anybody who has grade 3-4 encephalopathy is a high-risk patient.
If an INR is deteriorating,
high-risk patient.
Then you will consider.
Absolutely, you will consider. Because along with the deterioration of INR, the sensorium also will go bad. Because that all indicates that the liver is failing and you need antibiotics here.
So practically, except for grade 1 and 2, most of these patients will require
antibiotics.
Absolutely. Do you normally add antifungal as well?
Actually, lately we have started doing that. So when I was in Holiday Institute, we did a study on the profile of infection in acute liver failure patients. And at that point in time, we were using gram-negative beta-lactamase cover with a gram-positive cover, and we were not using antifungals. What we realized was 30 to 40% of patients were developing fungal infections while they were on broad-spectrum antibiotics. So then we changed our protocol and we started adding a fluconazole. And we also tried with voriconazole, but basically a azole has to be added, and that's a prophylactic antibiotic protocol.
So you advise that along with antibacterial in a patient who is deteriorating,
you probably need antifungal.
Okay. And what are the neurological signs one should observe regularly in these patients?
See, if you go by the recommendations, and that's what we do also in our unit, the moment the patient lapses to grade 3 encephalopathy, the patient has to be on ventilator. You have to electively intubate the patient, because that way the anti-cerebral edema measures can be better titrated. You can give them high dose propofol. You can give them hyperventilation during the episodes of...
you can reduce the movements.
Absolutely. You can reduce the movements. You can fix the neck in a particular position. So ICT, lowering many of these mechanisms are possible or intensified once you are able to intubate the patient. So a sick ALF will be on ventilator. So what you look for is, one, pupillary abnormalities. More important than the pupillary asymmetry is this reaction. Somebody has to carefully see whether it was brisk yesterday and going slightly sluggish today. So it's a comparative thing. It's not that you look at pupillary asymmetry. Once pupillary asymmetry happens, the patient is gone.
Edema.
Yeah, the patient is gone then. That means either there is edema which is going to cone, or the patient has an intracranial bleed. So it is not asymmetry we are looking at the briskness of the reaction. That is one. Secondly, most of these guys will be on propofol, so partial seizures. We are not looking at GTCS, contrary to popular belief. Look at partial seizures.
And I think only the EEG can tell the seizures.
Many a time, yes. Many a time,
they
yes.
don't have an obvious seizures.
So if a patient is deteriorating, I may even recommend that you may get a EEG done to see what is going on.
You know, most of the centers, they do not do ICP monitoring, even in these patients, with the fear of infections and bleeding. So what do you think? I mean, is it practiced? Is it advised?
Now, here there is a dichotomy. See, we have to understand that when we do ICP monitoring, we have to put a bolt inside the brain of the patient. So you have to drill a hole in the skull. You put a electrode inside the ventricles. The risk of bleeding is significant. The advantage you get by ICP monitoring is you know the surges of ICP rise, and you can titrate your mannitols and other measures accordingly to get the ICP down. But more often than not, it is offset by the 10% risk of bleeding which causes mortality. So even in the best centers in the world, the risk of bleeding after a bolt monitoring, ICP monitoring is 5 to 10%. So that obviates the benefit you are getting by that. So I guess except 3 or 4 centers across the world, nobody is doing ICP monitoring.
In these patients?
In these patients.
So now, one of the major treatment which improves survival in acute liver failure is a liver transplant.
That's right.
So when should you start thinking of liver transplant? Suppose a patient has come today in my ICU. When should I start thinking or start referring this patient to a liver transplant center?
So again, let's divide our patients into a low risk ALF and a high risk ALF. A low risk ALF, as we discussed, was grade 1 to 2 encephalopathy, some altered sensorium, understanding, but has coagulopathy and jaundice. Most of these guys would improve on conservative management. Once you go on to grade 3-4 encephalopathy, despite standard of care, the state of the art management, you are only able to save 50 to 60% of them. 40% are going to die. So, and which one is going to survive and which one is going to die after going into a high risk ALF, you can't predict. So in an ideal world, anybody who has grade 3-4 encephalopathy should be shifted to a transplant unit. Mind you, I am not saying should be transplanted. Shifted to it should be in a consultation with a transplant unit, because whether this patient is going to improve or worsen, you don't know. Once he worsens further, even the shifting may not be possible.
No, so that means even in grade 1 and 2, you should start considering shifting to a center. Because in grade 3-4, it becomes risky to shift the patient also.
I agree. So in an ideal world, ALF management should be in consultation with the transplant center, and shifting should be early. I understand that it may not be possible in all the cases. That's why we differentiate into high risk and low risk. But even in low risk ALF, you will lose some patients if you don't take a timely decision.
Now, there are various criteria, like we have been reading all the time, King College criteria, and there are some dynamic criteria. So, what do you consider which is more sensitive and specific? And how do you decide?
So, see, the most validated criteria across the world is King's College criteria. There's a lot of criticism of King's College criteria that it is a one-time evaluation. It has a specificity of 85% and sensitivity of, let's say, 60-65%. What it means in a layman's term is that you can predict who is going to die, but you cannot predict who is going to live. So even if you have good prognostic criteria, according to King's College, 1/3 patients are still going to die. So that is a fallacy of King's College. So now the world is moving to dynamic criteria. That means a daily evaluation. So you do criteria one day, next day you see what is the change, third day you see what is the change, and you decide which patient is best risk and worst risk. So let's say a guy comes to you with grade 1 to 2 encephalopathy on day 1. If on day 2 he remains grade 1 to 2, day 3 he improves, you are better off saying that this guy we are able to save. But on the other hand, same 1 to 2 encephalopathy, if he lapses into grade 4 on day 2, this is somebody which is worse. So that is the advantage of dynamic criteria versus static criteria. And the way forward in dynamic criteria came from our own country actually. I'm very proud to say that the first paper on dynamic criteria was published from All India Institute. Our mentor Dr. S.K. Acharya was the brain behind this dynamic criteria. It's called LFED score. I would suggest that everybody should go back and read that paper. This has been published in GUT 2012. And last year we had a single theme conference on acute liver failure, and I interacted with guys from King's College. King's College, you know, has almost 80% of published data on acute liver failure. And they are devising a dynamic criteria now based on LFED.
And now coming on to the management. Of course, the intensive care management is very, very important in the management of acute liver failure. But there are some specific to acute liver failure, like the role of N-acetylcysteine. We know that it has a role in acetaminophen poison, overdose. But what's its role in non-acetaminophen acute liver failure?
There is emerging evidence. Actually, I would say now it is good evidence that N-acetylcysteine does decrease all-cause mortality in all cases of acute liver failure. So it's a specific antidote for paracetamol, but it does work in non-paracetamol induced acute liver failure also. So in our liver unit, all ALFs will get NAC for 5 days. That's where we curtail.
How do you give it?
It's given as an infusion. The dosage is 150 milligram per kg per day over a 24-hour infusion. That's what we use over 5 days. Daily for 5 days.
And the other drugs which are quite useful in acute decompensation of chronic liver disease, are they useful in acute liver failure like lactulose and L-ornithine, L-aspartate?
There is good data actually to say that lactulose and L-ornithine L-aspartate both are, I would say, useless in acute liver failure. Actually, I would go on to say to the extent that they may actually be harmful. What happens is lactulose, what does lactulose do? It lowers the ammonia level in a chronic liver disease patient by binding the ammonia and converting into ammonium ion and excreting through stools. Now, the ammonia load in acute liver failure is much higher, to the tune of 100 times what we see in a chronic liver disease patient. It's not shown to be effective. Secondly, lactulose we know forms a lot of gases. So you load your guy with your patient with the lactulose of acute liver failure, he has some ileus, so his abdomen is going to bloat up. That is further going to cause trouble in the ICU management and even while transplant, if the patient lands up in transplant. So lactulose has been shown to be not useful, it should not be used. Similarly, L-ornithine, L-aspartate, we had again a randomized control. A lot of work from India in acute liver failure has come from All India Institute. So we had a RCT from All India Institute, which again showed that ornithine aspartate is not useful for acute liver failure patients, in contrast to acute and chronic liver disease.
You know, when a person develops cerebral edema, mannitol is one of the, in addition to the usual measures, and is a tendency to put it round the clock. Your opinion, how should we use it?
No, it's a big rider. Now, whenever I talk of ALF, this is something which I spend a lot of time on. Mannitol, if you use as a round-the-clock infusion, loses its effect. So mannitol has to be used as boluses during surges of intracranial hypertension. You identify by hemodynamic parameters. Somebody who has a baseline heart rate of 110, if he goes on to 150 or goes to 60, you know that this guy is developing cerebral edema. So you use mannitol as boluses, not as infusions. Secondly, you never write around the clock mannitol 6 hourly or 4 hourly. You decide on clinical parameters and use as bolus. And that's very important if you want to maintain the efficacy. Mannitol is one of the most important drugs we have for controlling or decreasing cerebral edema. It has to be used properly.
And ammonia, we were talking about ammonia. So what is the role of ammonia, and how often should you do an arterial ammonia?
Again, see, in acute liver failure, ammonia is a very, very important marker of the worsening liver failure, and it also indicates what is going to happen to the brain of this patient, how much edema is going to develop, in contrast to chronic liver disease. So I keep on telling my residents and everybody I work with that don't do ammonias in a chronic liver disease. On the other hand, acute liver failure ammonia is very important. Actually, the mortality has been directly linked to the level of ammonia. So any ammonia levels above 120, 130 indicate a poor prognosis. I do it every day in my patients. And now there is a new school of thought emerging that dialyze to decrease ammonia. Again, there is no level 1 evidence for that.
What are the other methods to decrease ammonia?
In acute liver failure, actually speaking, in acute liver failure, the routine measures like lactulose, L-ornithine and L-aspartate do not work. Rifaximin does not work. So the only thing you can do to decrease ammonia is, one, dialyze the patient. So continuous renal replacement or liver dialysis. Thirdly, change the liver.
You know, ammonia is directly related to the level of consciousness. And how often should you use it? I mean, you should do serum ammonia or arterial ammonia, and which is better out of these? That also I would like to know. And are there any measures to decrease it, or is there any benefit of decreasing it?
Okay.
All three.
So you can actually have a 1 hour session on ammonia in acute liver failure.
Okay.
So I'll take the questions one by one. First is ammonia important? Answer is a big yes. Ammonia is very important. Progressively increasing levels of ammonia correlate with the mortality in acute liver failure.
So prognostic marker.
It's a good prognostic marker. Any ammonias above 120, 130 indicates a very poor prognosis. 2. How and when we should do ammonia? It has to be arterial ammonia and not venous ammonia. Venous ammonias are lower than arterial ammonias. They don't give you a correct picture. So it has to be arterial ammonia. In our unit, we will do ammonia every day in acute liver failure to see which way we are going. And nowadays, there is emerging evidence that if you are able to lower ammonia artificially with medications or whatever, it does improve survival. Last question, how to lower ammonia? Now, unfortunately, we have no drugs available to lower ammonia in acute liver failure. So your lactulose will not work, your rifaximin will not work, your L-ornithine L-aspartate does not work. Only thing which works is dialysis. So renal replacement versus hemodialysis versus liver dialysis, all these lower the ammonia for some time and give the liver a chance to recover. And in the meantime, we talked about that.
Or do a transplant.
Or do a transplant, or livers recover spontaneously. So these are only 5 ways to decrease ammonia.
Okay. And you know, one of the other features of acute liver failure is a coagulopathy. And very often you will find the INR is raised. And there is a tendency to give the fresh frozen plasma. What is your take on this?
Now, this is a very, very important question, and this is where almost, I would say, 90% of ICUs go wrong. People who don't deal with acute liver failure will have a tendency to replace FFP or cryos or whatever to correct coagulopathy. Now, I would go to the extent of saying that this is actually harmful for the patient. The basic science behind coagulopathy of acute liver failure is the liver is not working. So you have a deficiency of procoagulant proteins and anticoagulant proteins. So it may not be a procoagulant state. So even an INR of 7 may not be a procoagulant state. Secondly, these patients are at high risk of going into fluid overloads. You give them FFP, they do develop fluid overload. Thirdly, you are exposing them to reactions without any scientific rationale of benefit. Fourth, and the most important thing is, your single most important parameter to decide whether the patient is improving or worsening is PT-INR. Almost all criteria which tell you whether the transplant is required or not required have PT-INR as a component.
So then INR will not be useful as a transplant criteria.
Absolutely. So you cannot rely on your criteria, and you can't predict whether this patient needs a transplant or not. So FFP use should be discouraged.
And even you should not use when you are putting lines, rather do an ultrasound guided procedures as far as possible.
So in our ICU, we do even central line insertions, we don't cover with FFP because we do internal jugular cannulations and we use sonocyte. So a pointed puncture inside the vein, you don't need FFP replacement. Arterial lines, we use peripheral arterial lines, we don't use FFP replacement.
Now, let me take you away from the acute liver failure. The other condition which we see many a times in the ICU is the decompensation of a chronic liver disease. How is it different? You know, like person has a cirrhosis and they land up in our ICU in an encephalopathic state with some infection and in organ failure. So how is it different?
They are two completely different diseases, I would say. So somebody has cirrhosis to start with and he has acute decompensation. So you are looking at a small liver reserve. On top of it, you have a liver injury. So ALF, you had a normal liver. You have a liver injury which either improves or the person goes to, you are not able to save the person, or the patient goes to transplant. In acute and chronic liver disease, the liver reserve is so less that the organ failure incidence is higher. The overall prognosis is worse. Even if acute and chronic liver disease patient recovers from the initial insult, the mortality risk in the next 3 months is to the tune of 70 to 80%, which is much higher than acute liver failure.
So acute liver failure is compared to the decompensation is not that bad. And a person who develops acute decompensation in a CLD patient has a more chances of dying.
Absolutely.
Because their 1 year survival is also very poor.
Absolutely. So 90% of these guys at the end of 1 year either will be dead or will be transplanted.
There also the transplant has a role.
Yeah.
And what are the risk factors for acute decompensation?
See, the biggest risk factor is underlying liver disease. So anybody who has cirrhosis has a risk of developing acute decompensation. The causes of, you mean to say what are the causes of
risk
acute?
Factors, precipitants.
So the commonest cause is infection. These guys already have cirrhosis, they are immunocompromised. So even small infections like I would say a boil somewhere or a spontaneous bacterial peritonitis or a chest infection or a pneumonia or a urinary tract infection can lead to decompensation. So they are sitting on a razor's edge. So infections are one. Secondly, primary hepatotropic viruses affecting a cirrhotic liver. So we understand that if you have hepatitis E in a normal person, 95% will be fine. 2 or 3% may develop acute liver failure. But if you have hepatitis E in a cirrhosis, 95% will develop acute and chronic liver failure.
Okay, and what else?
So AE. Thirdly, alcohol. So alcoholics, they go back to binge drinking. So somebody who's abstinent, one day he decides I'm good enough, my liver functions are normal and let's have a few drinks. Acute and chronic liver failure. So these are the 3 most common causes of acute and chronic liver failure in these patients.
And they said that constipation, GI bleed, and massive paracentesis.
So the constipation will precipitate encephalopathy. It will not cause worsening of liver disease. So the moment you give them laxatives and other things, they'll revert back to previous. GI bleeds, yes, because GI bleeds would lead to hemodynamic instability and it causes further liver injury. So they are a cause of decompensation. Massive paracentesis again precipitates without proper care. So massive paracentesis is not a problem. We actually do total volume paracentesis in cirrhotic patients, but we take care that we replace enough albumin. Again, the basic concept is the intravascular volume should not be depleted so as to affect the organs. So if you do a massive paracentesis without adequate albumin support, there is a risk of renal failure. And you know what happens once renal failure develops in a chronic liver disease patient.
And I think also if you give sedatives to these individuals, then also
Again, a sedative decompensation is an encephalopathic decompensation. It may not affect the primary liver disease, but yes, it does cause morbidity.
So how do you go about managing these patients?
You see, here again it is different. Here the patient will come to you in encephalopathy. You diagnose cirrhosis. You put them on anti-encephalopathy measures. Here, lactulose, rifaximin,
Ornithine
aspartate, all three have a role. You have to identify what is the decompensation. So, renal failure patients, if it is an acute kidney injury, you have to identify it is a direct kidney injury or hepatorenal syndrome, and accordingly you treat these guys. So, they may come with a GI bleed, so we have to control a GI bleed. We have to give first vasoactive drugs, and secondly we have to do an endoscopy, urgent endoscopy, which should be within 12 hours of presentation to control bleeding. So you deal decompensation wise in these patients.
So basically the precipitating factor, you should look for them and take care of them.
That's right.
And then the basic treatment.
That's right.
And in these individuals, lactulose and L-ornithine, aspartate and rifaximin do have a role.
Right.
And renal failure we see very commonly. And I have seen when these patients develop renal failure, their prognosis is very worse. And there are many causes of renal failure. So can you enumerate on them?
See, the interesting part and against the popular belief is that all renal failures in cirrhotics are HRS. If you see the longitudinal studies which have been carried out and which have detailed, investigated what is the cause of renal failure, the most common cause of renal failure is acute tubular necrosis. So, diuretic induced, GI bleeds induced, hypotension due to some other cause, total volume paracentesis, they all cause AKI. AKI mostly due to ATN. The second most common cause of renal failure in these patients is hepatorenal syndrome. Again, you have to preempt these things, then treat.
What is hepatorenal syndrome?
So, hepatorenal syndrome is where your kidneys are normal. The kidneys have no problems. You don't have an extrinsic renal toxic drug given to the patient, and they go into renal failure because of advanced liver disease. Now this happens when the effective intravascular volume decreases. That means you have a decompensated liver disease, there is exudation of fluid, the effective intravascular volume goes down and it directly causes low GFR.
So basically low perfusion of
the kidneys without any intrinsic kidney damage.
And how to manage this? Do terlipressin and all they have a role?
Actually they do have a role. So first thing is you need to expand the intravascular volume, you give colloids. Secondly, what you have is hepatorenal reflex. You are supposed to decrease portal flow, which you do by terlipressin. Once you decrease portal flow, the overall perfusion would improve to the kidneys and the kidneys actually start improving. So diagnose HRS, give them terlipressin, and along with terlipressin give them albumin. Most of the precipitants in these cases are infections, so you have to treat these guys with antibiotics, even if you are not able to document infection. So every hepatorenal syndrome patient should be on antibiotics because invariably the precipitant is an infection. And these are all endogenous infections, they come from the gut of the patient because of altered permeability.
And if a person has a massive ascites, and so what I'm trying to say that when do you do a ascitic tab?
In acute decompensation of chronic liver failure, every time. So a patient, not every day, at the time of presentation to the hospital. So if somebody comes to you with acute on chronic liver failure, he has ascites, you have to rule out spontaneous bacterial peritonitis. The commonest precipitant, as I said, is infection, and the commonest infection is SPP. So please do a paracentesis at the time of presentation, at least a diagnostic one, to see whether you have infection. It may give you a culture report, it may guide your sensitivity, antibiotic sensitivity, and it has a lot of benefits.
So acute liver failure is a condition, patient do come in the ICU, and acute liver failure is diagnosed with a person has a jaundice, encephalopathy and coagulation abnormality within 26 weeks of the onset of jaundice or the liver abnormalities in the absence of cirrhosis or chronic liver disease. When you encounter such a patient, you have to take a detailed history, you take a detailed history of drug intake, because some of the drugs can really cause a very severe acute liver failure which can have a very disastrous consequences. In addition to the usual treatment of any intensive care patients, there are certain things which are very important in the management of acute liver failure. You do a diagnostic workup to find out the etiology, and you also do a prognostic and the management workup of these individuals for maintaining everything normal during the period of illness. And the first thing when these patients enter into the ICU, I think one has to find whether this is a candidate for liver transplant. Ideally, patient above grade 1 and 2 encephalopathy should be managed in a liver transplant unit. Then which patient to go for a liver transplant? The King College criteria has been used all over the world and still being used, but now the dynamic criteria are becoming more popular and are probably more sensitive and specific to tell about the prognosis in a patient. And then there are certain things which should be done in these patients, and any patient who has any additional organ failure or grade 3 or grade 4 encephalopathy should be on antibiotics, and probably, depending on your experience, probably an antifungal along with it. If the person has a coagulation abnormalities, the fresh frozen plasma is not indicated. It can not only hinder your decision to send a patient for transplant, it really doesn't help these patients. Then the lactulose and L-ornithine aspartate, which are more useful in acute decompensation of chronic liver disease, are detrimental if you use in these patients. If these patients develop renal failure, then probably, and if there is an indication of dialysis, CRRT is the preferred because it will not fluctuate the intracranial pressure. Intracranial pressure monitoring is usually not done in most part of the world, but this is one of the important things which one has to manage, because anybody who has more than grade 3 has some amount of cerebral edema and which needs to be managed, and they need to be intubated, and all the measures which you apply to decrease intracranial pressure should be practiced, like putting the head at 30 degree, not disturbing the patient, using propofol, and in certain patients thiopental, and even hypertonic saline has also been used in these individuals. Then the main treatment, if it is possible, is the liver transplant. The mortality without transplant, if a good medical management, 50 to 60% patient can survive. But if you do a transplant, a lot of additional patient, up to 70% or 80% patient can survive with the liver transplant. The acute decompensation of a chronic liver disease is a totally different disease which has a much worse prognosis than a simple acute liver failure. And these patients, the infection is the commonest reason for these deterioration. In addition to the usual ICU management or a critical care of these patients, if they have ascites, you should do an ascitic tap to find out whether they have a bacterial peritonitis. Then the lactulose, L-ornithine aspartate and rifaximin, they have a use in these patients, and they can decrease the encephalopathy, and you should avoid sedative because they can decompensate these individuals who are normal. Again, for a chronic manage or for the long-term management, the liver transplant is one of the treatment for these patients who present with acute decompensation in a chronic liver disease. Thank you, Dr.
Thank you.